Continuing education credits for physicians and other healthcare professionals is provided by VCU Healthcare Continuing Education. Check out cribsiders.vcuhealth.org for more information.
The Cribsiders podcast is for entertainment, education, and informational purposes only. The views and statements expressed on this podcast are solely those of the host.
All right, welcome back to the Cribsiders.
Hey, y'all.
I'm Justin Bird, joined tonight by wonderful co-host Dr. Chris the Jew Man Chew, and our phenomenal producer and showrunner Sam Mazer. Say hi, Sam.
Hey guys, how you going?
We had an outstanding guest tonight, Dr. Mike Fahey, returning to discuss supraventricular tachycardia. But before we get into the content, let's talk about the show. Chris, tell us what we do.
Well, we are the Pediatric Medicine Podcast. We interview leading experts in the fields to bring you clinical pearls, practice-changing knowledge, and answer lingering questions about core topics in pediatric medicine.
We have a fantastic conversation with our guest, Dr. Mike Fahey, who comes to us from the University of Massachusetts, where he is Chief of Pediatric Cardiology and Program Director for the Pediatric Residency Program. He is the recipient of multiple teaching awards across all training levels, and today he teaches us how to approach narrow complex tachycardias, discusses the multiple types of SVT, treatment, and gives us his bundle of info.
You guys, I know it's a longer one, but you got to stick with it because it's heart-stopping, almost like getting adenosine.
Thanks. Welcome back, Dr. Mike Fahey, to the second round of the Cribsiders. We're so excited to have you. Welcome back.
Thanks very much. I had a lot of fun last time, and I'm happy to be back.
Well, we are lucky to have you because as we were just talking about congenital heart disease, the previous episode was extremely popular. People clearly loved it, and it's very exciting to give people part two. We like to give people what they want, and I think this episode is really going to go a long way.
Yeah, I hope so. Congenital heart disease. Who couldn't love congenital heart disease, right? and today we're going to get into arrhythmia. Who couldn't love talking about arrhythmia, right?
Palpitations. Just thinking about it, I think that's palpitations joke number one for this episode. We'll probably have one in the intro too. We've done some of the get to know you questions before, but to remind our guests, do you mind telling us a little bit about yourself? Give us the one-liner, remind our guests who you are and a little bit about you.
Yeah, sure. So again, I'm Mike Fahey. I'm Chief of Peds Cardiology out at UMass Memorial Medical Center, affiliated with now UMass Chan Medical School out in Worcester, Massachusetts. And I also run the Pediatric Residency Program out there. I'm a recovering fishing addict. I think I mentioned that last time. Oh, guys, I was in the Adirondacks last week fishing for big brook trout. It was unbelievable. But now I'm back to reality.
You know, there's a little bit of a sad rivalry now between Providence and Worcester because a neighboring city of Providence, Pawtucket, had the minor league Red Sox team, the Paw Sox. They're now the Woo Sox.
They're the Woo Sox.
And it's kind of heartbreaking because we no longer have a minor league baseball team in Rhode Island.
I totally understand your pain because the Woo Sox are awesome. The new Polar Park in Worcester is just killer, and we're pretty stoked about it. But I am sorry for your loss.
I don't want to hear about it.
Okay, we don't have to talk about it.
Chris or Sam, do one of you have a get to know you question maybe that we haven't done, or?
Sam, you go first. I'm thinking still.
I think we actually did. Thank you last time for answering our questions for both our favorite failure and best advice. So the other question that we usually ask our guests is if there was a book you might recommend, anything that a physician should read or just anything that you're reading or that we could always entertain Justin with.
Yeah, gosh. It took me about 10 years to get through the Fire and Ice. What is it? What do you call five book series?
Game of Thrones.
Yeah, Game of Thrones. Yeah, exactly. Oh, yeah. So I finally got through those after I watched season 1 and I was like, oh, I like this show a lot. I think I'm going to read the books. And that only took me 10 years to do. I just finally got through those this summer. I don't recommend that. My favorite books are, I love Lonesome Dove. Man, that book, I cried like a baby at the end of that book. Love that book. But I was thinking before also about a book I haven't read in a long time. Sophie's Choice is unbelievable. I love Power of One is unbelievable. Anyway, but gosh, I just don't have time to dig into good books the way that I used to. Sam, I did think about another important failure that had to do with arrhythmia, and maybe we can get into that a little later.
Go for it.
Oh, maybe we can.
Later.
Oh, later.
Well,
later.
Yeah, no. I guess we could do it now. So I'll try not to make it too long because it's kind of an involved story. But basically, I got called by the NICU when I was on call many years ago, and we're going to talk in this episode about how to diagnose different arrhythmias. And this attending, who was great, super sharp gentleman, and who really knew his stuff, he essentially was telling me that this kid was in a wide complex tachyarrhythmia, and so it looked like ventricular tachycardia, and I'm but the kid was totally fine, stable, breathing normally, normal blood pressure, normal perfusion, everything. So I was like, this isn't VTAC, this guy's got it wrong, and so just it's probably SVT. We'll talk about SVT in a little bit. SVT with aberrancy, which can make SVT look like a wide complex arrhythmia. And I said, give the adenosine and let's just see what happens. And I'm thinking they're going to give the adenosine and this kid's going to convert, and it didn't convert. And I said, are you sure your IV's hooked up right? Like, I'm really giving this guy a hard time, And then I'm finally like, fine, I'll come in and I'll figure this out. So I'm like, give me the adenosine, and I'm like hooking up the three-way stopcock and the whole thing. I'm like, I'm going to show these guys how it's done. And sure enough, I give the adenosine and nothing happens. Nothing happens. And I sit there, I'm like, what is going on here? And it wasn't until I did it myself that I sat back and I thought, well, adenosine's not working. This kid actually is in VTAC. And we'll talk about like maybe why that is later. But and the kid happened to be in an extremely rare arrhythmia, idiopathic VTAC, which you can see in infancy sometimes. And it tends to be a pretty hemodynamically stable rhythm, unlike other forms of VTAC. And it usually, if you can get them out of it, it usually just kind of resolves on its own, and then it just doesn't come back. And again, super rare, but it was a learning point for me to say, and this happens in medicine all the time, right? Where you come into a case always thinking about your last case or with your own kind of preconception of what's going on. And it's always super important to doubt yourself and to say, like, what else could this be? Like, because and this happens, for example, with cardiac imaging all the time. If you go in with an impression of what you're going to see, your brain is going to make your eyes see what you want to see what your brain wants you to see. And so it's always important to go into cases with a blank slate, get the information, make your analysis, and try not to come in with too many preconceived notions as to what's going on.
That's right. Whenever I'm in the PICU and get an EKG, it's always idiopathic ventricular tachycardia until proven otherwise.
That's a great story, and maybe we should just jump right into it. What do you think, guys?
Let's do it.
All right.
Sounds good.
Take us away, Sam.
All right. So our first case from Cashlack Children's is Wolf P. White. So he is a 5-year-old previously healthy boy. He's presenting with chest pain. He was playing basketball with his older brother in the driveway when his chest started to hurt. He ran into the house and pointed at his chest, and his mom felt like his heart was beating really fast, and so she took him to the doctor. So in your clinic, his heart rate is 190 beats per minute. An EKG is done, which shows a narrow complex tachycardia. So providers will often say, quote, this kid is in VTAC. But what does that actually mean?
All right. So before we get into it, I mean, we just in this initial question, we already started to get into some terminology, and I think it makes sense to take a step back for a sec. And let's just talk about the normal conduction system of the heart and like what a normal cardiac impulse is like, because talking about arrhythmias, we pretty quickly get into terminology, and that makes things super confusing. So let's just go to like bare bones, like bare basics, and build up from there. So we're going to like kind of imagine in our heads from medical school, right? You learn that the electrical system of the heart starts with the sinus node, and the sinus node lives in the high right atrium, kind of near where the superior vena cava joins with the right atrium. And all heart muscle cells have automaticity. Automaticity means that if you leave those cells alone long enough, they're going to depolarize on their own. They don't need any kind of stimulus to get them going. They just automatically depolarize. And as it turns out, the sinus node has the most automaticity of anything in the heart. So the sinus node is the group of cells that kind of beats the drum. It's the group of cells that dictates the cadence of the heart rate. And so the electrical signal starts with the sinus node. That electrical signal kind of cascades through the upper chambers, through the atria, like waves going through a pool if you were to throw a stone into it. And that electrical wavefront goes through the atria, and then it goes all the way down to the ventricles, but then it hits a stop, right? Because remember from your anatomy that there's this fibrous ring between atria and ventricles that electrically insulate the atria from the ventricles, except at one place, and that's the AV node. So the AV node lives right at the junction between atria and ventricles, and the AV node's job is to receive that signal from the atria, hang on to it for a split second to let the kind of blood flow catch up to that electrical signal, and then the electrical signal goes extremely rapidly through the His-Purkinje system that carries that electrical signal into the ventricles, and it's that extremely rapid conduction that causes all that ventricular myocardium to depolarize in a very short amount of time. And we'll talk about this in a minute, but all that ventricular myocytes depolarizing in a very short amount of time is what gives you a narrow QRS complex. We're going to talk about narrow versus wide QRS. And remember, the QRS complex is the thing on the EKG that shows you what's happening with ventricular depolarization. In order to have a nice narrow QRS, you need to have a normally functioning His-Purkinje system. So if you ever see a narrow QRS, you know that signal came through the AV node, through the His-Purkinje system, and did what it was supposed to do. Then that signal goes back up through the ventricles, and then it would go back right up to the atria, but it can't, because remember, the ventricles are electrically isolated from the atria, and so that signal can't make its way back up. Everything goes back into its refractory state, and then you start back up from the top at the sinus node, and then you go again. All right, so that's the quick refresher. So now let's get into what's going on with this kiddo. So 5 years old, comes into the office after feeling like his heart was racing, and I think he said he felt like a little dizzy, right? And maybe a little chest discomfort, is that right?
Had some chest pain, yeah, exactly.
Yeah. And the heart rate was 190 beats a minute, I think he said?
Yep.
Yeah. So for a 5-year-old, 190 beats a minute, well, theoretically, if we had this kid on a treadmill and we were like maxing him out, he could get his heart rate up that high. Remember, your maximum sinus rate is dictated by the formula. The fastest possible heart rate is 220 beats a minute minus your age and years. So theoretically, if he was running around on a treadmill, he could get his heart rate up to 190. Or if he was, really, really sick with something else, right? He was in septic shock or something like that. Theoretically, he could get his sinus rate that high. But this is a kid who's walking into your office, so his heart rate is not going to be that high, right? So yeah, so just right off the bat, when you see a persistent heart rate that fast, you know that you're probably dealing with some sort of arrhythmia. And the fact that the kid is sitting up talking to you, that's your first tip-off that this is probably not an immediately dangerous arrhythmia, like it's not, for example, a ventricular arrhythmia, and therefore it is likely what we're going to be spending most of this time talking about, which is supraventricular tachycardia. So to unpack that word a little bit, or that term a little bit, if you look at your PALS algorithm on, if anybody looks at a PALS algorithm for how to deal with tachyarrhythmia, the first branch point the first thing to decide is the patient like really sick and unstable, or are they okay, are they sitting up talking to you? But the next step is to figure out, are you dealing with a wide QRS tachyarrhythmia or a narrow QRS tachyarrhythmia? And that gets to what I was talking about before. If it's a narrow QRS tachyarrhythmia, you know that signal came through the AV node and is going through the His-Purkinje system the way that it was meant to. And so right off the bat, if it's a narrow QRS, that is supraventricular tachycardia. So so SVT is an umbrella term for all those fast arrhythmias with narrow QRS. And there's a lot of them. There's a lot of different ones. And that's when you start getting into like the alphabet soup of EAT and PJRT and AVNRT, and it makes your head spin. So I think it makes the most sense to talk about things kind of mechanistically and try not to get too bogged down in the terminology. So the first step when you're evaluating a kid with a heart rhythm that's too fast is, first question always is, hemodynamically stable or not? Because if not, that takes you down another pathway. You're going to treat that patient very differently than if you're dealing with a hemodynamically stable patient. And if the patient is hemodynamically stable, the overwhelming likelihood is that you're dealing with SVT.
I always had a question in all the different types of SVT, sinus tachycardia, which is supraventricular, which is above the ventricular, does that count? Is
Yeah,
that one of the SVTs that we just forget about?
yeah. I get, so technically, sinus tachycardia, I guess you could say is SVT, but most people, when they use the term SVT, they're talking about an abnormal rhythm. They're talking about a rhythm that's not generated by the normal conduction system of the heart. So when I give this talk to medical students and residents who are rotating with us in cardiology, I usually preface this by saying, we're not talking about sinus tachycardia today. We're talking about tachyarrhythmia. So, it's a not normal heart rhythm.
So we just said that, supraventricular tachycardias are those that exist above the AV node, and they're narrow complex. And so, Justin just brought up one of them being sinus tach, but we're going to kind of skip that. So what are the other most common ones that we might see in children?
Yeah, so the most common form of SVT in kids, and again, I want to steer away from terminology as much as I can, but you can't get away from a couple of terms. The most common type is atrioventricular reentrant tachycardia. And these terms kind of describe the path of the electricity. So atrioventricular, so it's a pathway that goes from atria to ventricles. A reentrant. So reentry implies that there's some sort of loop of electricity that's happening. And so in AVRT, there has got to be another way for electricity to get from atria to ventricles, or from ventricles to atria for that matter, so that the electricity, instead of just going from top to bottom and then it can't go anywhere anymore, it goes from top to bottom and then has some way to get back up to the atria to then go back down the AV node and his Purkinje system, which again gives you that narrow QRS. Then it goes back up to the atria and then back down the AV node and his Purkinje system to give you your next narrow QRS, and so forth. So AVRT is the most common form of SVT that we see in kids, and the kind of prototype of AVRT is Wolf-Parkinson-White syndrome. That's the most common predisposing condition to that reentrant type of arrhythmia.
And just to clarify on exactly what that is, the reentry note, when you describe the electricity of the heart to begin with, you mentioned that the atria and ventricles were isolated except at the AV node. In AVRT, am I right to say that that isolation is with the exception of the AV node and a re-entry pathway?
That's exactly correct. And some people in Wolf-Parkinson-White, this extra pathway is often referred to as a bundle of Kent, but whatever. We usually just call it an accessory pathway. It's another place other than the AV node where electricity can get between atria and ventricles.
And so when the heart rate is going 190 beats per minute, for example, we're trying to make one of these diagnoses. We would like to get, as most people would probably imagine, is an EKG or some form of rhythm strip. How do we make that diagnosis via that 12 lead? And this may be challenging to talk about without imaging, as we're doing an audio podcast, but we'll see where we can get.
Sure. So if you were in your office and you had the luxury of having an EKG machine right there, you would put the leads on the patient and do kind of a rhythm strip and kind of have a look at what you're looking at. And again, the first thing in the algorithm that you would think about is, are we dealing with a wide QRS tachyarrhythmia or a narrow QRS tachyarrhythmia? And if it's narrow, you're talking about supraventricular tachycardia. And the hallmarks of reentrant SVT are that your QRS complexes are going to be extremely regular. Because if you think about it, those QRS complexes, the ventricular beats are happening every time the electricity goes once through that circuit. And so if we have a little circuit of electricity, it's just, it's a little electric circuit that has its own frequency. And as a result, it's going to be extremely regular. Every time that electricity makes a pass through the ventricles are going to squeeze. And so you're going to get an extremely regular heart rate. Importantly, you will occasionally see a little bit of wobble, so to speak, where the QRSs don't exactly march out in perfect intervals, but it should be awfully regular. It should be really quite regular, and that's to differentiate a reentrant rhythm from something that we would call an automatic type of tachycardia. There are also automatic types of tachycardia which are a bit more rare, and those usually happen as the result of an extra pacemaker that you have that decides to wake up and cause trouble. So for example, the most common automatic type of tachyarrhythmia would be ectopic atrial tachycardia, or EAT. And that's when you have, essentially it's like having an extra pacemaker in your atria that doesn't play by the rules. And every once in a while it's going to decide to wake up and cause trouble and start beating faster than the sinus node. And because it starts beating faster than the sinus node, it takes over control of the heart rhythm. But that first step, if you have the luxury of having an EKG, is looking for those, looking for the R to R intervals. So how much space is between each QRS complex. Is it very regular or is it irregular? And then you kind of take things from there.
And the one follow-up question to that is just trying to differentiate between, just normal sinus tachycardia and also this tachyarrhythmia that we're concerned about. How do you best differentiate the two?
Yeah, so remember the requisite features of any kind of sinus rhythm are: you got to have a P wave before every QRS, you have to have a QRS after every P wave, and that P wave should look like it's coming from the sinus node. Namely, that P wave should be upright in lead 1 and upright in lead AVF, because lead 1 sits out to the patient's left. So if the beat's coming from the sinus node, it should be moving from the patient's right to left. And AVF is straight down. So if, again, the beat's coming from the sinus node, that wave should be moving from top to bottom. So those are our 3 requisites for sinus rhythm. And so if you're an SVT and that rhythm isn't being generated by the sinus node anymore, you'll see narrow QRS complexes, but you won't see P waves. So the P waves will be missing from the equation.
And you mentioned that a lot of this is very dependent on the EKG. Before we go into even some of the more nuances, is there any information on history or family history or chief complaint that helps guide the algorithm in your mind or the process? Or is it really just heart rate's high, get an EKG, and start marching out with the calipers?
Yeah, sure. So again, first and foremost, in evaluation of any tachyarrhythmia or a suspected tachyarrhythmia, is hemodynamic stability or not. Because if not, you're going to move right into a much more aggressive treatment strategy. This is a 5-year-old kid that we're talking about, and so the history is probably going to be a little bit fishy. Some 5-year-olds are more expressive than others, and some of them can describe that their heart feels like it's racing. For some reason, I've heard a ton of younger kids describe it as their heart beeping, B-E-E-P-I-N-G. I don't know why, but I've heard several kids describe it that way, which is kind of cute. But anyway, so there's, the most common symptoms in a kid this age would be, if they can express a sensation of their heart racing. Oftentimes there's associated chest pain, oftentimes associated dizziness. Fainting, on the other hand, or loss of consciousness, is quite rare with SVT. So if you ever have a kid where the chief complaint is a fainting episode, you should immediately start scratching your head and wonder if this is something different and maybe a little bit more insidious and dangerous than SVT. In a younger kid who might not be able to express what's going on, for example, an infant, the types of things that we look for are unexplained irritability. Now, of course, infants are irritable, like that's what they do, right? But it's kind of, all right, it's not just they're fussy, you fed them and they're still fussy, or, they're so fussy that they're not feeding, you change their diaper, they're still fussy, they're just, they're not sleeping, they're just fussy. Those are the kinds of things. And, sometimes associated with color changes. In the congenital heart disease podcast, I think we talked about how, we always ask about color changes. And people usually think that we're talking about cyanotic congenital heart disease, but really kind of what we're fishing for there is this kid in a high adrenaline state or not? And the high adrenaline state seen in congenital heart disease is often times also seen in kids who are in tachyarrhythmias. And so they'll get some of those peripheral color changes as well. The blueness around the lips and mouth, maybe of the hands and feet as well. Maybe a little bit of sweating that goes along with that. Babies, especially if they've been in SVT for a while, they'll oftentimes start to exhibit signs of, tachypnea, rapid breathing, labored breathing. And again, that's a sign that they've been in SVT long enough that their cardiac output is starting to get compromised, and they're starting to get a little bit of backup into the lungs that's causing some of those respiratory symptoms. So there's a few historical things that can give you kind of hints as to what's going on, and those are a little bit different depending on the age group that you're taking care of. Other historical factors, family history, most arrhythmias don't really have a very strong heritability. There is some data to suggest that there's certainly a higher incidence of WPW, for example, Wolf-Parkinson-White syndrome in first and second degree family members of individuals. I think the information is something like your risk is 2 or 3 times higher to have WPW if you have a first degree family member who has WPW, but we don't really understand the genetics of that. If you talk about older folks, there definitely seems to be some genetic susceptibility to things like atrial fibrillation, but that's more in adult medicine, not so much pediatrics. AFib is a very rare arrhythmia in pediatrics.
And any other SVTs that we should have on the differential? What about AVNRT?
Yeah, so you'll hear a lot of people talk about AVNRT. So what does that mean? So AVNRT stands for atrioventricular nodal reentrant tachycardia. So we just chucked an N in the earlier term that we talked about, the AVRT. So now we just throw a nodal right in the middle there. And AVNRT, rather than having an accessory pathway outside of the AV node, you actually have that little reentrant loop of electricity happening within the AV node itself. So, when we draw a picture of the conduction system of the heart, we always draw the AV node as just like a little ball, and then there's like a line that comes off it, which is the His-Purkinje system, right? Like, remember, the AV node is this like really complex bundle of fibers, right? And you can imagine that within that bundle of fibers, you might have some that conduct a little bit faster, some that conduct a little bit slower. And in AVNRT, what happens is that those fibers are arranged in such a way that a loop of electricity can exist within the AV node itself. And so that little reentrant loop that we were talking about before is spinning round and round inside the AV node. And every time it spins around, it sends a signal down to the ventricles and it sends a signal up to the atria. So it's kind of depolarizing both atria and ventricles with each little spin of electricity. It's theoretically possible to discern AVNRT from AVRT on an EKG, but frankly, it's real difficult to do. It's got to be at absolutely perfect tracing, and even in perfect conditions, like you can't always do it. So, and frankly, honestly, discerning between AVRT and AVNRT, that's the job of the electrophysiologist. Like, even as a general cardiologist, I'm not concerned with that at all. In the discussion of SVT and its treatment and its diagnosis, that's too detailed for even the general cardiologist. And I think that's when people, I think, their head starts to spin around because there's too many little details. So I think it's much more practical to kind of think about the general mechanisms by which these things are happening, because then if you understand the general mechanisms, that really helps you to understand, well, what are we going to do to treat the patient, and how are we going to prevent this from happening in the future?
So we just touched on actually some awesome points, but including how these children often present and what goes into this. We also talked about when the kid comes to clinic, we have to find out, are they hemodynamically stable or not? But when that also happens, do we need to order any other diagnostic tests, or do we just try to break it now and worry about a workup later?
Yeah, so for example, if let's say you had a baby or this 5-year-old come in and they're not looking so great, their color's a little off, their breathing seems labored, they really seem uncomfortable. That's a kid that you're probably going to want to get out of your office and into the emergency room as quickly as you can. But in the meantime, let's say you called 911 and an ambulance is on its way. And you feel the pulse and you feel like it's very, very fast. You feel like it's very, very regular. You're not going to hurt anybody by trying vagal maneuvers to try to break somebody out of SVT. And so when we talk about vagal maneuvers, there's a lot of different ones, and we can try different things depending on different age groups. You learn in adult medicine the carotid massage, right? You kind of rub on the carotid arteries there. And the idea here, and we should back up a little bit and say vagal maneuvers. What's a vagal maneuver? So these are different exercises that you can do, have the patient do or do to the patient that tries to stimulate the vagus nerve. Because if you think back as to what the vagus nerve does, the vagus nerve is that nerve that kind of slows everything in your body down, right? It's the rest and digest nerve. And from a cardiac perspective, what vagal stimulation tends to do is it slows sinus node automaticity. So if you're in sinus rhythm and you do a vagal maneuver, you'll slow sinus rate down. And it also slows down AV node conduction. And that's the key part when we're talking about vagal maneuvers as treatment for SVT. Because in reentrant forms of SVT that use the AV node as part of the loop, if we can get that AV node to slow down a little bit, what's going to happen is, as that really rapid loop of electricity tries to get down the AV node, if we can just put the brakes on the AV node a little bit, that very rapid electrical signal is going to find that the AV node is refractory. It will not have recovered fast enough to be able to conduct anymore. And if that happens, that loop of electricity will break, that circuit breaks, and once it breaks, what happens? Oh, well, the next most automatic thing in the heart is going to be the next thing that fires, and that's the sinus node. So in other words, if you can get that loop of electricity to break by slowing conduction through the AV node, that circuit's going to break and you're going to go back into sinus rhythm. So vagal maneuvers slow AV node conduction, and there's a number of things you can try. In kids, probably the most effective one, for example, the 5-year-old that we're talking about, would be to get a straw and have them blow as hard as they can through that straw. Or in a younger kid, maybe, I don't know how many pediatric offices have like pinwheels, but you have them like, imagine that they're blowing on a pinwheel, or imagine that they're blowing out birthday candles or something like that. No, Jimmy, blow harder. You got to get all the candles out, So you try to get them to blow really hard. And the idea there is that you're trying to get them to do a Valsalva maneuver. Now, if you tell a kid, bear down, that's what everybody says, bear down like you're having a bowel movement. I mean, Johnny's going to look at you like you have lobsters crawling out of your ears, right? Like he's going to have no idea what you're talking about. So for kids, you got to kind of break it down into terms that they understand. So blow out the birthday candles, blow through this straw or whatever it is. For younger kids, so for infants, we have a few more options. The most commonly used vagal maneuver probably for infants is the ice to the face. The right way to do that is you get a bag, you put some ice in it. Importantly, you put some water in it and you kind of shake it around so you have a nice like slurry of ice and water, because that's going to give you much better contact of that cold surface. And you put the bag of ice, importantly, don't put the bag of ice over the whole face, right? Because we don't want to smother the poor baby. So you put the ice kind of over the upper part of the face, over the eyes, over the cheeks, and that sort of thing. And just kind of apply gentle pressure, hold it there for 5 or 10 seconds, and then you kind of break, and the baby's going to be mad as hell at you. But if you feel the pulse and it's slowed down, you've done your job. Other options for babies is stimulating a gag reflex. That'll sometimes work. Another very commonly used vagal stimulus in infants is rectal stimulation. So, you take a rectal temperature or something like that, and that can also work actually as a vagal stimulus to get babies out of SVT.
I remember being the intern in the NICU, and we had one of the babies in the feeder grower section went to SVT, and I remember running to the ice machine and filling up the bag and then just throwing it on the baby, and it worked. It was like the craziest thing. I was like, whoa.
Yeah.
About the blowing of the straw, I heard about this and a similar thing with adults. The REVERT trial came out a couple of years ago, and they looked at blowing. They used a 10 cc syringe as well, and then they also added make someone supine and a leg raise at the same time, and they called it the modified Valsalva maneuver. I don't know if for our older kids, is that something that we can also do?
Well, it's really interesting because older kids. In older kids who have kind of frequent episodes of SVT, like let's say, for example, we have them on medicine that kind of keeps them under control, but they still have breakthrough episodes here and there, they kind of figure out what works for them. I've had several kids figure out that doing handstands or headstands gets them out of it. So kids will do all kinds of crazy stuff, and hey, whatever works, right? So I don't know that we've done the data on headstand versus ice to the face versus 10 cc syringe or pinwheel or whatever, but it's kind of, you try a bunch of stuff and you end up figuring out what works for the patient.
So Dr. Fahey, let me ask, when the patient's now in the emergency room under the wonderful care of Dr. Mazur, what's the concern about letting the SVT continue? Why are we worried that this 5-year-old's heart rate is 190 beats per minute? How long can a 5-year-old go with this fast of a heart rate. And so what's the big concern with SVT?
Yeah, that's a great question, because I think the first knee-jerk reaction when you're seeing any kid who's in SVT with these super fast heart rates, remember, sometimes we're talking about heart rates up around 300 beats a minute. That's scary for almost anybody. But actually, despite that, SVT is usually not immediately threatening to somebody's health. Certainly at those very faster heart rates, you have a much higher likelihood of having circulatory problems, because if you're beating at 300 beats a minute, you don't really have enough time to fill those ventricles, and so your cardiac output's going to get compromised. But kids can maintain these very fast heart rates for remarkable periods of time. It would be very unusual for a kid to get into any sort of significant trouble in SVT, even if they've been in it for a few hours. I would say, as a general rule of thumb, we'd start to get a little, and the length of time that we kind of tolerate or that we feel comfortable is related to how fast it is. So obviously, if you have a kid who's in SVT at 300 beats a minute, they're not going to tolerate that nearly as long as a kid who's in SVT at 180. But generally speaking, kids can tolerate SVT for several hours at a time without getting themselves into too much trouble. Once you start getting into beyond that, they've been in SVT for 10 hours, for 20 hours, that's when the risk of progressing toward what we call a tachycardia-induced cardiomyopathy, that's when that risk starts to really elevate.
And does that present with signs of decompensated heart failure?
Yes, 100%. So then you're really talking about a kid who's got cool extremities. You can feel the pulses maybe, but they're very thready. Yeah, you're going to start to notice perfusion and blood pressure problems. So the presentation of a kid who's in SVT, who's kind of going into heart failure, that's a sick-looking kid. It's not the 5-year-old who's sitting up talking to you. It's a kid who's got color changes, who's got respiratory distress, who's got those peripheral perfusion changes, and oftentimes starting to have hypotension as well. That's how those kids definitely will start to look when they've been in it for a long time. So in a 5-year-old or certainly in an older kid, we're going to have a much more reliable historian to kind of let us know when their symptoms started, so we can be much more confident about how long they've been in the arrhythmia. In an infant, it can be much more difficult, right? Because they can't say, "Hey, mom and dad, I started having palpitations 3 hours ago." They may have been in that tachyarrhythmia for a full day before the parents even knew what was going on, because a lot of times an infant, they might not exhibit many symptoms early on, and it might only be after they start to decompensate that it becomes obvious that there's something going on. So we definitely get a little bit more concerned with our infants who are presenting in SVT for the first time, because it's really impossible to know how long they've been in it. And again, the major concern, other than the immediate problem of kind of congestive heart failure that they can have, is this tachycardia-induced cardiomyopathy. Basically, they've been in a demand. They have this demand ischemia for long enough that it actually causes damage to heart muscle. And even after you get them out of the SVT, they can have residual ventricular dysfunction.
So now we're in the ED, and Dr. Mazur here is taking care of the patient. He's got a couple more. If he's in the emergency department, he's got hopefully more things to his disposal. What are some other temporizing things or things that he may be able to do compared to if I was in some other outpatient setting?
Yeah, I think pretty much if a kid is fairly stable, you've tried all the vagal maneuvers and they're not working for you, generally speaking, we will jump right to the next kind of step in the algorithm, which is administering adenosine. And if we think about, remember, adenosine is a medicine that's only given IV. It has an extremely short half-life in the bloodstream, 6-7 seconds, something like that. And we can think of adenosine as kind of vagal maneuvers on steroids. It actually completely shuts down the AV node for a few seconds. And so those reentrant types of tachyarrhythmia that utilize the AV node as part of the circuit, adenosine should really work for all of them. So you're going to need IV access. I can't tell you how many times a kid has broken out of SVT as the IV is placed. So I wouldn't recommend placing IVs in kids as like a mechanism to break SVT. But because you need an IV to administer adenosine, that you actually oftentimes see a stimulus like that result in them breaking out of it. But then, adenosine, the first time you give adenosine, it always terrifies you. We always joke around, like, get the cardioversion paddles out just in case, and then you put them on yourself because you're having like a heart attack as you're giving this kid adenosine. Because remember, if you administer adenosine appropriately, what you should see on the monitor next is a flat line, right? Because you're totally interrupting the signals between atria and ventricles. And so you shouldn't see anything. And so these kids flatline for a few seconds, sometimes 7-8 seconds. And that's pretty scary, but they always come back. They always come back, guys. So don't hold back on that adenosine. It's gonna work for those reentrant forms of SVT that use the AV node as part of the circuit.
Now, adenosine has to be it's got to be pushed, right? Because of how short the half-life is. You're trying to get it to the heart, right?
That's exactly right. So, this probably isn't going to work if you have like a 22 gauge IV, like in the big toe, that's probably not going to work for you. You try to get an IV in like the antecubital vein or something like that. And you always hook up a 3-way stopcock. You have the adenosine. So one port is open to your IV, one port is open to the adenosine, and one port's open to a good 10 cc syringe of saline. And what you do is, once everybody's ready, and by the way, it's always great whenever you're doing either an adenosine cardioversion or an electrical cardioversion, you have somebody running a rhythm strip while you're doing it, because a lot of times you'll get a lot of information from a cardioversion as you silence that AV node. So you have somebody run a rhythm strip, and then you rapidly push the adenosine in, and then you close off the stopcock to the adenosine, so then your flush is open and you very rapidly push in your flush to try to get that bolus of adenosine to the heart before its half-life expires. And again, the better you can do that, the better chances you have of breaking that arrhythmia. And sometimes looking at that rhythm strip, especially when you're not successful in breaking the SVT, it's important to look back at that rhythm strip and figure out what happened. Because if you, for example, I gave you that example before where I gave that poor neonate 2 or 3 extra doses of adenosine because I was convinced that they were in SVT, and they weren't. So guess what? I was giving the kid adenosine, and I was shutting down their AV node. But that didn't do anything because that particular kid, their arrhythmia was generated from the ventricles. So I could have given that kid an adenosine drip, and it wouldn't have done anything. There are other times where, for example, atrial flutter is another type of SVT. We see it pretty rarely, but we do see it, especially in neonates. A flutter can be a good mimicker of AVRT. And the key there is that A flutter is another type of reentrant SVT, but the difference with A flutter is that atrial flutter is a reentrant loop where the loop exists entirely within the atrium. So again, if your reentrant loop exists entirely within the atrium, if you give that kid adenosine or you do vagal maneuvers or whatever you're doing to shut up the AV node, you haven't done anything to the reentrant loop. So you'll give that kid adenosine, their heart rate will go to 0 because that reentrant loop can't communicate with the ventricles anymore. But then as soon as the AV node wakes up again, the kid goes right back into the arrhythmia that they were in before. In other words, you get the ventricles to stop beating, but you haven't treated the arrhythmia itself. You haven't treated that reentrant loop. And atrial fibrillation, the same thing applies. So in atrial fibrillation, you have a more complicated reentrant loop, usually in the left atrium. You can give that person adenosine, and you'll get the ventricular rate to go to 0. But then as soon as the AV node wakes back up, you go right back into the arrhythmia that you started in. So sometimes when you give adenosine and the kid is still in SVT afterwards, if you call me as the cardiologist, I'll say, hey, did you run a strip while you were doing that? Because I'd like to look at that. Because sometimes what happens is it actually is AVRT, and you break them out, and then they just happen to go right back into it. And that happens from time to time. And that's an important thing too, because if you have a kid where you successfully get them out of the SVT, but then they go right back into it, well, heck, we can give them more adenosine and get them out of it, but they might just go right back into it again. So then you're just like giving them shot after shot of adenosine. That's not going to do anything for that poor kid. So if we saw that you broke it, and then the kid went right back into it. We probably have to change our strategy to change the conduction system in a little bit more of a long-lasting way. For example, using other medications.
So how many times would you try it? I think with the PALS, you do your second dose at double the dose, and then after 2 and you look this strip and you're not doing it, or maybe 3 times. I mean, like, how do you normally go about that?
So it really depends. The critical question is, did adenosine break the arrhythmia or not? And the only way you know is by having that rhythm strip running while you're doing it. So for example, you give the adenosine, heart rate goes to 0, you see that nice flat line, you see a couple of sinus beats, hey, you broke it. But then boom, they go right back into SVT. I think it would be reasonable to give another dose of adenosine just to see if, maybe you got unlucky and they had a little aberrant beat or something like that triggered SVT again. But if you do it, say, twice and you're clearly breaking it and they're going back in, I wouldn't bother. You got to change up your strategy there, because that just indicates that whatever is going on in that kid's heart, they're just very much predisposed to SVT in this environment. And you just got to change the overall conduction of their heart in a different way to try to keep them out of that SVT.
And what would be your next go-to medicine? I know there's a lot of different cardiologists like their go-to 1A blocker of various different types. I'm curious what yours might be.
Yeah, 100%. So one thing I'll say here is that adenosine is a very specific medicine that we use to try to convert kids out of reentrant SVT, specifically reentrant SVT that uses the AV node. Other type of antiarrhythmic agents, the most common would be beta blockers, because beta blockers are safe, they're easy to get, they're easy to administer. You have IV forms, you have oral forms, so you got a lot of choices there. And most importantly, beta blockers are safe. As you go to different antiarrhythmic agents from that, for example, people oftentimes use things like procainamide or something like that in the emergency department to convert SVT. That's another very safe, relatively short-acting drug that's not terribly pro-arrhythmic. As you get into the more and more kind of big gun antiarrhythmics, remember, antiarrhythmics, they're basically poisoning your heart, right? So in different ways. And so the more potent the antiarrhythmic agent you're using, the more the potential to trigger other nasty arrhythmias. So, and the specific antiarrhythmic agent you use really depends, honestly, on where you trained and who trained you and what antiarrhythmics they like to use. We have very little data that really prove the point of, X antiarrhythmic agent works better than Y antiarrhythmic agent for example, run-of-the-mill AVRT. Beta blockers generally work fine, but some kids are refractory to beta blockers, and then you got to use something stronger than that. The next step up would be something on the lines of probably sotalol or flecainide, and this is more for like kind of chronic therapy, or using some of those medicines in combination. Those medicines, things like sotalol and flecainide, they have different, you monitor them different ways. Some, flecainide, you have to get drug levels in the blood, you have to check regular QT intervals and that sort of thing. So it gets a little bit more complicated once you get beyond that. And frankly, once you get beyond beta blockers, I almost always run those patients by my electrophysiology colleagues, because that this isn't something that I do every day. I'm certainly very comfortable with beta blockers, and certainly even comfortable with maybe low dose of the next step of antiarrhythmic agent. But I don't hesitate to just give somebody who does this day in, day out a call and say, hey, what do you think about this? And hey, am I getting this dose right? Just always double check with somebody who really knows what they're talking about.
I usually consult cardiology after the second dose of flecainide. That's when I am like, we should really bring an expert into this.
Once you've triggered VTAC in a kid comes with SVT and you triggered VTAC by overdosing them with flecainide, then you call the cardiologist.
Yeah, that's when know you're ready for someone's help.
Good technique.
Yeah.
Now, Mike, when will we cardiovert? Like, say if they are stable, I know if they're unstable, I think you're going to try to cardiovert them, right?
Yeah, that's right.
If they're stable, is there at some point you're like, maybe I should sedate them and cardiovert them electrically?
So if you think about it, and this is a good time to talk about basic mechanisms, right? So we talked about the mechanism by which adenosine works. Adenosine works by shutting off the AV node transiently. Let's talk about electric cardioversion. So how does electric cardioversion work? Well, you're delivering an electric charge to all the heart cells at all the same time, so they all depolarize at the same time. If you deliver enough energy, right? You'll depolarize all those cardiac cells all at the same time. And if you successfully do that, everything depolarizes, everything becomes refractory. So there's not going to be any reentrant thing possible. And then what's the next thing that happens? The most automatic thing in the heart starts up again. So your sinus node starts, and then you go back into sinus rhythm. So electricity, in contrast to adenosine, will work for any reentrant heart rhythm. So AVRT, AVNRT, but also A-flutter and A-fib, which are reentrant rhythms that exist entirely within the atria. But if you're depolarizing everything at the same time, electricity should, or I should say has the potential to work for any reentrant SVT. And the time at which you use electricity, first and foremost, would be in a patient who's hemodynamically unstable, and you just know that you got to get them out of that rhythm as fast as possible. That would be the first thing. I would say there are very few instances where you would use electricity for a type of SVT that should respond to adenosine, right? Because if you give enough adenosine in the right way and you document that you've shut the AV node off, well, that really should work for any reentrant rhythm that uses the AV node as part of the circuit. It might be that you've given adenosine and it hasn't converted you're looking at the strip and you're like, I just don't think that we ever converted this person out. Or you give adenosine and you recognize that once you shut up the AV node, you see those flutter waves, right, underneath the pattern of QRS complexes. Once the QRS complexes go away, all of a sudden that sawtooth pattern of A-flutter kind of comes out. Well, then you know that adenosine isn't going to work and you're going to move to electricity in that standpoint. I guess the only situation I could think of where, other than hemodynamic instability, where you would jump to electricity, you can't get IV access in the kid. Sometimes I've seen even adenosine delivered by IO. I mean, poor kid.
I was going to ask about IO adenosine.
You can do it, but again, it takes a while for that adenosine to get through, the marrow and into the bloodstream. I have seen it work, but I wouldn't recommend it. I'd frankly say, that would be a situation. If I couldn't get IV access, I'm not confident that an IO is going to cut it, because I'm not sure that adenosine is going to get through that bone up into the bloodstream, up to the heart in time. So that would be a situation, if I couldn't get IV access, that I might move right to electricity in that situation.
And just to kind of finish up this question, is there any contraindication to adenosine or anything that we should be looking out for, or just go for it, and if it doesn't work, call the cardiologist?
Yeah, so the one, if you spend any time in the emergency department, there's one contraindication that you'll hear people talking about all the time, and that's in a patient with WPW. And we've referenced WPW a couple times here in this talk, but I don't think we've really unpacked that a little bit, and I think it's worthwhile just taking a second to talk about what we mean by WPW. So Wolf-Parkinson-White is a type of AVRT, atrioventricular reentrant tachycardia, where your accessory pathway, and remember the accessory pathway is that extra place where electricity can get between atria and ventricles. That accessory pathway can conduct electricity from top to bottom and from bottom to top. And the top to bottom portion of the conduction is what's unique about WPW. So let me kind of explain what I'm talking about. Do you guys remember there's two kind of hallmark EKG findings in Wolf-Parkinson-White? Do you guys remember what those are?
Delta wave.
And Delta wave is one of them.
And the short PR
Short
interval.
PR.
And the short PR interval, exactly. So let's think about why those things come about. So with WPW, you have an accessory pathway that can conduct from top to bottom. If we think about that sinus beat going through the atria, okay, it's going through the atria, it's going to get down to the AV node. And, as opposed to the normal heart, now the electricity, it hits the AV node, which is going to slow, it's going to hang on to that electrical signal for a second. But if there's an accessory pathway somewhere else, that could conduct without any delay, well, that electrical signal going through the atria is just going to jump right down into the ventricles. And what that does, that shortens your PR interval, right? Because you don't have that delay anymore between conduction from the atria down to the ventricles. You don't have to wait for the AV node to get it down into the His-Purkinje system. It's just jumping right over through the accessory pathway into the ventricles. So that's what gives you your short PR interval. The delta wave, and again, we're going to have to imagine what a delta wave looks like. But a delta wave is kind of like a slurred upstroke of that QRS. The beginning part of the QRS is it's not sharp straight up and down. It's kind of slurred on a lower slope. And what's going on there is that, remember we started off this talk by talking about a narrow QRS, and that conduction through the His-Purkinje system gives you a nice narrow QRS because all that ventricular myocyte is depolarizing in a very short amount of time. If the electricity is going through an accessory pathway and not using the His-Purkinje system, that electrical signal is going to conduct. It's going to conduct, but it's going to conduct through gap junctions between the ventricular myocytes. And that's going to get through pretty fast. It's electricity after all. But it's going to be a lot slower than the His-Purkinje system. And so if we were to just leave that electrical signal going through the accessory pathway and we just let it go through the ventricles, it would look a lot like a PVC, a premature ventricular contraction, a wide, nasty-looking QRS. But what happens is that it starts off looking like a PVC. It starts looking like a wide QRS. But then by the time the electricity gets, a quarter or halfway through the ventricle, that signal that was hanging out in the AV node, that makes it down the His-Purkinje system. And so the rest of the ventricle depolarizes normally. So it's almost like a fusion beat between a PVC and a normal QRS. And that's what gives you that delta wave. It kind of looks like a wider QRS, but it's that beginning part of the QRS that's wide. So those are the two findings in WPW that give you the hint that there's an accessory pathway present. All right, so that's WPW. Well, why do we care? Who cares? This stupid accessory pathways conducting antegrade. Why does that matter? When you're in sinus rhythm, it doesn't matter at all. Having that short PR interval and delta wave doesn't do anything to you. Very rarely, actually, if your accessory pathway is in the wrong place, it can cause actually ventricular dysfunction because it causes your ventricular depolarization to happen in a way that causes the ventricles to not beat in a synchronous kind of way, and so they kind of compete with one another. That's very rare, but so rarely people with WPW will have a little bit of ventricular dysfunction as a result of where their accessory pathway is, but that's pretty rare. The main reason that we care about it is patients who have WPW are at a significantly higher risk of developing atrial fibrillation. We don't know exactly why that is. That has something to do with the accessory pathway itself. And you might say, well, AFib, okay, that's a little weird, but we don't see it in kids very much. Well, why do we care about that? Adults get AFib all the time, right? And they're generally okay. The reason we care about it is that, generally people survive when they're in AFib because they have an AV node to protect their ventricles from going way, way too fast. Remember, fibrillation, if we think about atrial flutter rates of that's usually like 300 beats a minute, 350 beats a minute, something like that. Well, AFib, the atria are beating so fast, they're not even beating, right? They're fibrillating. They're just jiggling around. And that's because the atrial rates are so fast that you can kind of barely even count them. If you had an accessory pathway that could conduct at, 500 or 600 beats a minute, well, what's to stop those electrical signals from jumping across that accessory pathway and causing your ventricles to beat at 500 or 600 beats a minute? And what do you call that? That's VFib, and VFib is lethal. So that's why we care about Wolf-Parkinson-White, is that not everybody with Wolf-Parkinson-White, but importantly, a subpopulation of people with Wolf-Parkinson-White, they have to have an accessory pathway that can conduct very rapidly, and they have to develop AFib. And if those two things happen, that results in sudden cardiac death. And that is, thankfully, an extremely rare complication of WPW, but the risk is not zero. And that's what really kind of keeps us up at night as cardiologists when you make that diagnosis of WPW and you're counseling those parents. It's a very difficult conversation to have because it's a very rare but very devastating outcome. And there's not really any medical treatment that will prevent that sudden death. So patients with WPW, we generally opt to refer them for ablation therapy, so an invasive catheterization to find that accessory pathway and get rid of it.
And so in the patient that's in the emergency department with SVT unknown to be WPW, or even if they did have WPW, does the adenosine itself, I imagine it's blocking the AV node, so you're only having that reentry pathway, but does the adenosine itself increase your likelihood of AFib, or does the adenosine itself lead to any worse complications?
Yeah, Justin, so thanks for getting me back on task. I got on that segue of kind of talking about what Wolf-Parkinson-White was, but yeah, so this critical thing of like, when would you not give adenosine? There's this kind of thing that you'll hear in emergency departments of, oh, you never give the patient with WPW adenosine. And what they're getting at is, if you happen to have a patient coming in who has a known history of Wolf-Parkinson-White, and they happen to be an AFib, all right, you can imagine a situation where some of the signals from that AFib, from those fibrillating atria, some of the signals are making it down the accessory pathway, and some of them are making it down the AV node. And because there's kind of competition for the attention of the ventricles, so to speak, the ventricles are kind of maintained at a reasonable rate. And if you gave that patient adenosine and you shut off the AV node, that could potentially remove that competition, and then you would get kind of unfettered conduction of that atrial fibrillation down the accessory pathway, and that could precipitate ventricular fibrillation. But I go against that mantra, because I think if you don't necessarily, just do algorithms, and you don't necessarily do knee-jerk medicine, and you take a second to think and look at the data that's in front of you, you can figure out whether a patient is in AFib and Wolf-Parkinson-White or not. Because if you think about it, what are the hallmarks of atrial fibrillation? What do you guys remember about that?
Yeah, I mean, you have the sawtooth pattern of the P waves.
Oh, wait a minute. That's a flutter.
Oh,
What about AFib?
Irregularly irregular?
Irregularly irregular, right? Yeah, so it's like the QRSs, they're kind of all over the place. There's not any rhyme or reason to their cadence at all. Narrow QRS, right? And let's see, if the first, we started off talking about reentrant SVT, that was going to be very, very regular, right? So if somebody comes in an SVT, you're going to have very, very regular, narrow QRS complexes. So the first tip-off that you're dealing with somebody in AFib, you're not going to see a regular pattern. You're going to see an irregularly irregular pattern. Okay, that's the first thing. The second thing is, what are signals going to look like? What are the QRS complexes going to look like if they go down the accessory pathway? Are they going to use the His-Purkinje system? No, right? We just talked about how, oh yeah, you get this delta wave because it's not accessory pathway conduction doesn't get down the His-Purkinje system. So any signal that goes down the accessory pathway, that's going to give you a wide QRS complex. So somebody who's in is in that rare situation of they have WPW and they're in AFib, you're going to see a irregularly irregular pattern, and you're going to see a mix of narrow QRS and wide QRS. So that's what you should see. If somebody has a history of WPW and they come in and they are in narrow QRS, dead regular, they're not an AFib. And I would say call us first for sure, but you can feel pretty comfortable, giving that patient adenosine. And guess what? If there were any doubt, you would give electricity, right? You would just do electric cardioversion, which shouldn't put them at any increased risk, and theoretically could treat their AFib as well, right? So I guess getting back to your earlier question, Chris, like, oh, when would you use electricity instead of adenosine? I guess that would be another situation. Anytime that a person with known WPW came in and you weren't 100% sure they were in SVT, and you thought, oh man, maybe they're in AFib, and I'm going to kill this guy if I give him adenosine. Yeah, I guess that's probably a pretty good reason to get the paddles on them and use electricity instead.
Well, and can I ask too, as far as adenosine versus beta blockers, is there ever, I get that, adenosine gives you the information, it stops the AV node entirely so it can break that circuit. But as you mentioned, especially in chronic, if you could slow the AV node down just enough, does that ever break an SVT? Would you ever just do, I know in adults with an AFib with RVR, sometimes we'll just do a push of metope or something. Is that ever a reasonable thing before electricity or for any other instances? Or is adenosine that much better?
Well, yeah, adenosine, again, you need an IV to place it. If, for example, in some of our kids where we know they have SVT, they're out in the community and they have a breakthrough episode, sometimes the first thing that we tell them to do is, hey, as long as you're not feeling too bad, take an extra dose of your beta blocker and hang out for an hour and see if and then try your vagal maneuvers again and see if it works. Frankly, most of the time that works. Give them a little bit of extra beta blocker, have them hang around for an hour, again, as long as they're feeling okay. And then repeat vagal maneuvers and see, because sometimes, right, you slow them down a little bit more with an extra dose of beta blocker, and then all of a sudden that vagal maneuver works because you've slowed down the AV node that much more in order for it to work.
Gotcha. So afterwards, so you say you've broken their SVT and you're trying to figure out what to do with them now.
Mom's crying and hugging you.
Yeah.
Just trying to paint a picture.
So some of my questions are like, are there other tests we should do? Should I be checking a thyroid? Should I be doing other labs? Like, do I need to be doing that as well in part of the post-care?
Yeah. So if you're dealing with a more unusual arrhythmia, like if you saw a flutter or AFib or something, that would be definitely, checking a thyroid level would definitely be something that you'd want to do. It's very common to get an echocardiogram as part of the initial workup. And that's because people quote that, people who have SVT have a much higher incidence of congenital heart disease. And it might be something subtle like a small atrial septal defect that escaped detection before. Frankly, most of the time when we've diagnosed SVT out of the blue, I frankly don't oftentimes find congenital heart disease associated with it. But if you look at the literature, they quote pretty high incidences of congenital heart disease as compared to the general population in people who are diagnosed with SVT. But other things to do, an echocardiogram I think would be important to do, certainly in any infant that you've just converted, because again, we don't necessarily know how long they've been in it, and you want to make sure that you're not dealing with a dysfunctional, heart. So that would be an important thing to do. But outside of that, no, there's not a lot of other testing other than, getting a new baseline 12 lead after they're out of SVT. So you can say, for example, do they have WPW or something else? And yeah, again, echocardiogram, maybe, and definitely yes, if it's an infant and or you're not sure how long the kid's been in it.
This is actually a perfect transition to going back to Wolf. So Wolf did return to normal sinus rhythm, and then we did repeat our EKG, and of course we identified a short PR interval and a delta wave. So we kind of hit on the diagnostic criteria already as far as testing goes, but just want to double check, did we make a diagnosis of WPW syndrome with just that EKG, or did need any of the echo or any of the other testing to actually make that diagnosis?
No, WPW is a purely ECG diagnosis. And remember, you don't know, when the patient's in SVT, you can't diagnose WPW. WPW, those features that we said, short PR interval, delta wave, you need antegrade conduction down the accessory pathway. When you're in SVT, the electricity is going down the AV node and up the accessory pathway, and then down the AV node. And you say, well, wait a minute, how do you know it's going that way? How do you know it's not going the other way? You know it's not going the other way because if it was going the other way, you'd have wide QRS complexes, right? We began by saying it's a narrow QRS. So you know the electricity is going down the AV node through the His-Purkinje system and back up. And because of that, you'll never see the delta wave or the short PR interval when the patient's in SVT. You got to break them out first, and then they go back into sinus rhythm, and you get that antegrade conduction, and then the WPW pattern comes out.
So for a kid like Wolf, who actually did have an episode of what we're calling an SVT, as well as a diagnosis of WPW, do kids like him go on preventative medicines?
Yeah, so we usually do whenever, so if you diagnose a kid who's in SVT, you break them out. Yeah, they generally, so you could argue it both ways. I would say that it would not be wrong to have a first-time SVT diagnosis. You just kind of wait and watch. And that would be particularly safe to do in an older kid who's going to be able to tell you in the future, hey, I'm having palpitations again, or I'm having chest pain or difficulty breathing or whatever. In an infant, we would err a little bit more toward maybe treating them to be putting them on preventative beta blockers or something like that. Certainly if a kid, let's say a kid was in the hospital, you've seen them have a couple of episodes of SVT, you got them out of it, but then they go back into it. That generally means that they should be on a preventative medicine. But every once in a while you get a kid where they go into SVT, you break it, and then you just never see it again. So it is reasonable to consider, especially in an older kid who can reliably tell you what their symptoms are, it would be reasonable to not treat them and just wait and watch.
Can you do like a pill in pocket type for some of those who are symptomatic?
Yeah, you theoretically could. And that probably gets to how frequently they're having breakthrough episodes. For example, let's say we had a teenager who, once or twice a year, they get into SVT. And boy, when they get into SVT, you just cannot break that SVT with vagal maneuvers. They're always coming into the emergency room. They're getting the adenosine, the whole bit. That would probably be the situation where I would say a pill in pocket technique might be worthwhile. And when we say pill in pocket, what we're talking about is you don't go on daily therapy, right? Like, I'm going to take a beta blocker every day to prevent a once a year episode. Like, that just seems excessive. So some people will do a pill in the pocket where they just carry around a dose of beta blocker, or theoretically something a little stronger like flecainide or something like that, where when they feel the symptoms, they take the pill, they hang out. And if their symptoms, don't resolve within an hour or two, you send them to the emergency room for kind of more definitive therapy. Generally speaking, I would say the pill in the pocket approach, I sometimes will do in my teenagers with atrial fibrillation. I generally don't do it so much with my kids with more kind of run-of-the-mill SVT.
And so what's your go-to preventative medicine? Do you usually do beta blockers? And if so, there's a lot of beta blocker choices out there. Just curious where you generally start.
Yeah, sure. So in the younger kids, you're going to want to use something more short acting, because if you ever overshoot, in a little baby with a long acting beta blocker, you could get yourself into trouble. So with the baby, we're usually using short acting propranolol, which is a 3 times a day medicine. Sometimes as they get a little bigger, you can transition them to twice a day medicine. And usually, a starting dose of propranolol would be something like 2 milligrams per kilogram per day in divided dosing. As kids get bigger, as they're able to tolerate pills, we pretty rapidly, when they can tolerate it, transition them to a once daily beta blocker just for ease and convenience. And really, once you get to that point, it's dealer's choice. It's atenolol or metoprolol succinate, which is the long-acting form of metoprolol. You can use nadolol. There's a bunch of different choices, and you can trial different things. Oh, and hey, there's long-acting propranolol these days too, right? I mean, that wasn't around when I was in training. So there's a lot of different choices, and sometimes one beta blocker works better for a certain individual than others. So if you fail with one beta blocker, it's totally reasonable to try a different one to see if you can, get a little bit better efficacy out of a different one.
Can Wolf play sports?
Good question. So, people worry that a high adrenaline state, A, will increase the risk of them going into SVT, and maybe more importantly, B, theoretically could accelerate that antegrade conduction. And so if they were ever to go into AFib, they could maybe more likely go into VFib. We generally don't restrict our kids with WPW from athletics. But again, as soon as they get to an age and size that's amenable to catheterization, and the size is usually around about 25 kilograms, is about the minimal size that you can get away with, where an electrophysiologist can do a catheterization without risking harm to blood vessels by putting all those electrophysiology catheters in there and everything. So once a kid gets to about 25 kilograms, that's generally when we start to think about referring them for ablation for Wolf-Parkinson-White. But before that, you have a really long conversation with the parents, right? And you say, these are the risks. They're extremely low. Importantly, those preventative medicines that we talked about before, while they decrease the risk of SVT, they do not decrease the risk of sudden death in association with AFib. So that's a really important point.
And you had just mentioned about ablation as well. I think just to cover, again, we kind of talked about it in the beginning, but who would you send for ablation entirely? And does everyone with Wolf-Parkinson-White ultimately go for ablation?
So if you were to diagnose an older kid with WPW, let's start there. The benefit of having an older kid is that there's one non-invasive test that you can do to try to risk stratify them to see if you think that they are high risk Wolf-Parkinson-White. And when I say high risk, what I mean is they have an accessory pathway that can conduct very, very rapidly versus a low risk Wolf-Parkinson-White, which is, sure, they have an accessory pathway, but that sucker can't conduct very rapidly, right? If your accessory pathway can only conduct at 150 beats a minute, if you go into AFib, dude, you got no worries, right? I mean, you can't go into VFib from that. So the way you figure that out is, again, if you have an older kid or a teenager with Wolf-Parkinson-White, you can put them on a treadmill and you stress them. You just try to rev up their heart rate as fast as you can get it. And as they're exercising, if you see that short PR interval and delta wave go away, what that means is at those faster heart rates, that accessory pathway, it cut out. It couldn't handle those faster heart rates. It couldn't conduct antegrade anymore. And that predicts if you were in AFib at those extremely rapid atrial rates that you don't develop VFib. So an exercise stress test is something that can be helpful in your older kids. But in your younger kids, unfortunately, so certainly any documented VTAC or VFib, that buys you an ablation immediately. Any kind of unexplained incident, so a kid presents with unexplained syncope, and then you discover that they have Wolf-Parkinson-White, hey, you don't know what happened. If you don't know what happened there, that kid, gets an ablation immediately. But really, any kid where you don't know the conduction properties of the accessory pathway, we generally err on the side of caution and refer them for ablation just because of the risk of that very bad outcome.
Usually one of my last questions before we finish wrapping up is, looking at the future of SVT treatment options, what's on the horizon? Are there any cool things that you know about that are going to be tools for us as physicians in the future that we can use for our patients with SVT?
Yeah, so, ablation technology is getting better all the time. I think that there's going to be hopefully less risky invasive ways of mapping out these accessory pathways and ablating them. Right now, that 25 kilogram limit, that's a really tough thing, right? If you diagnose a baby with WPW, the counseling is, okay, mom and dad, we can treat your baby with beta blocker to prevent SVT, but we still haven't mitigated the risk of sudden death, and we're just going to have to wait until your kid gets to about 25 kilograms and then refer them. And that's anxiety that nobody wants to deal with. So hopefully technology will continue to improve to the point where we can do diagnostics and invasive diagnostics and ablation procedures in younger kids. And of course, there's always the possibility of more effective medicines that might prevent kids from going into SVT in the first place. Yeah, so those, nothing definitive on the horizon for now. But those are the things that I'd be looking toward in the future.
Sorry, I do just want to ask one more question that I forgot about. And this, I was really curious. It's happened to me a couple times. What about if WPW was just diagnosed incidentally on an EKG? Completely asymptomatic, for example, came into the hospital, had something like pneumonia or something like that, bradycardic overnight, got an EKG, and you saw what we would consider WPW pattern. Are all the same things we applied, or do we need to call the cardiologist? Or is this something that's just like, hey, it's incidental, don't worry about it?
Oh yeah, no, definitely call the cardiologist with those incidental cases, because that might be your one moment in time where you've captured that. If you make an incidental diagnosis of Wolf-Parkinson-White, that definitely warrants a call to the cardiologist. That might be the one moment in time where you're able to capture that patient and kind of manage them appropriately. It's well known that rarely, but importantly, sometimes people present, their first presentation of Wolf-Parkinson-White is actually when they present in VFib, which is again a lethal condition. So that's a kid who definitely needs to be monitored. They definitely need to be they either need an exercise stress test or they need to be referred for ablation.
Great. So I think, we covered a lot. We started from approaching, a narrow complex tachycardia, talking about the different types of SVT with the ectopic atrial tachycardia, with re-entry tachycardia, the AV node, or through a different accessory pathway. We talked about vagal maneuvers, some antiarrhythmics, and indications for ablation and electricity cardioversion. This has been really wonderful. What do you think? What are the main take-home points for listeners for the show about SVT that you want people to walk away with?
Yeah, so I would say the first thing dealing with tachyarrhythmia is always remember that kind of first question. Are we dealing with a hemodynamically stable or unstable patient? Because if the patient's unstable, we're moving immediately to electric cardioversion and more invasive therapy. If the patient is hemodynamically stable, hey, you can take a couple breaths, get an EKG, think a little bit, kind of assess the patient a little bit more, try to figure out what's going on. Remember that SVT, importantly, is usually not immediately life-threatening, so you have time to think. You have time to look at the rhythm strip. You have time, if you want to call a cardiologist and look things over. You don't have to run around and immediately cardiovert that patient, because generally speaking, they're going to remain stable for a long time before they get into any kind of trouble. And then, the next step is always to get a picture of what those electrical signals look like, get that patient on a monitor, an EKG if you have it in the office, or if not, know that you have time to get that kid to the emergency department where they can get those diagnostic tests that they need. And if you happen to be the one in the emergency department, follow your algorithm. That's what they're there for. Again, you're going to have time to look at your card and take a deep breath. It's going to be okay. The patient's not going to crump in front of you. You have time to think about it and treat it appropriately. But yeah, again, whenever you're in situations like that and you're uncertain or you're confused about what you're seeing, that's what your friendly neighborhood cardiologist is around for. And give us a call and we can help sort it out for you.
Nice. We cannot thank you enough for all of your insights and sharing your time with us. Anything that you would like to plug? Anything that we should send our listeners to have them check out after this episode?
Oh no, this is my only gig, guys. I don't have anything else going on.
Easy enough.
Awesome.
Well, again, thank you so much for sharing your time, your expertise. We really, really appreciate you. And I think this is an outstanding episode.
Oh, great. Thanks, guys. It was a lot of fun, as always. And let me know if there's anything else you guys want to chat about.
All right. Hey, appreciate you.
The number you have dialed has been changed. The new number is...
So this has been another episode of the Cribsiders.
It's for the kids.
Get show notes and sign up for our weekly Knowledge Food Formula Feeds newsletter on our website at www.thecribsiders.com.
We are committed to providing you with high-value, practice-changing knowledge, and to do that, we need your feedback. So please subscribe, rate, and review the show on Apple Podcasts, or contact us at thecribsiders@gmail.com. A special thanks to our producer for this episode, Sam Mazer. Special thanks to our showrunner for the show Cribsiders, Sam Mazer, and our wonderful social media team on Twitter, Instagram, and Facebook. I've been Justin Lee Burke.
I've been Sam Mazer.
And this has been Chris the Chu Man Chu. Thank you, and good night, good morning, evening, afternoon. See you guys.
Hey, you've already listened to the entire episode. Now claim CME credit. Continuing education credit is provided by VCU Healthcare Continuing Education. VCU is accredited to provide continuing education to the entire healthcare team. Check it out at cribsiders.vcuhealth.org for more information and to claim your credit after listening to this episode.